where I'll be talking about what is Wheeze and very briefly about a stepwise approach to diagnose asthma according to the British Thoracic Society guidelines, give you certain clues to alternative diagnosis. What are the supportive investigations which might direct you towards a diagnosis of asthma or otherwise? Some case examples and when you should consider referral either to a secondary care pediatrician or a tertiary respiratory pediatrician. And as Liz said at the very end, there will be a mini test of 4 or 5 questions where I'm happy for you to shout out answers if you haven't gone to sleep at the end of this talk. So, just going through the British Thoracic Society guidelines, I'm sure all of you have looked at it. There's not much evidence to any of these guidelines, but as I say, it's only guidelines. So as you can see in the square here, the evidence is based on manuscripts which are rated D. So very briefly, you suspect asthma in any child with wheezing on auscultation. That is the absolute basic. So the auscultation is important over here because you need to distinguish it from upper airway noises, and you have to hear a wheeze, an expiratory wheeze on auscultation. And then you base the diagnosis of asthma in children who have the presence of key features and whether they have any other alternative diagnosis that might come to mind. Response to trials of treatment, particularly with inhaled corticosteroids, with ongoing monitoring and assessment. You would do a trial of 6 to 8 weeks to see whether they've responded to the treatment or not. And of course, you question the diagnosis of asthma if your management or your trial of inhaled corticosteroids is ineffective. And you record the criteria on which the diagnosis has been made, so there is continuity of care, and the person who sees the child the next time will know whether you actually heard a wheeze or you decided to label the child asthmatic based on other criteria. So what exactly is wheeze? Wheeze is only a symptom, and it is a whistling noise which is heard due to narrowing of the small airways. So it is not diagnostic of asthma. So any condition which can cause narrowing of the small airways will produce wheeze. It is usually appreciated only on auscultation of the chest and is the most common physical finding in asthmatics. But as I will show you later on in my talk, not all that wheezes is necessarily asthma, but it is most likely to be due to asthma. It is just an audible manifestation of airway oscillations, which is caused by airflow limitation, as you can see here, irrespective of the underlying cause of this airflow limitation. So going on that theme, a wheeze is not always what it seems to be. I'm just going to show you 3 videos which we use mostly in the research setting to show parents video clips to identify whether the noise which they are describing as wheeze is actually wheeze. And there are several languages which do not have wheeze as a term in their language. So the child could be having stridor, just having a rattle, and the parent might be describing this as wheeze. So let's play this. So I just want a show of hands, or do people think that Okay, I hope that wasn't too noisy, but whether you could identify. I ideally would do it as a test, but because this is virtual, so I will tell you that is inspiratory stridor, that is not wheeze. I'll play that again. So if you concentrate, it's more on inspiration that you hear the noise. The second one is a child with nasal obstruction, so upper airway obstruction. So he's a mouth breather and he's breathing quite harshly. And the last one is a wheeze. So all these three parents had presented to hospital saying that their children had wheeze. And it was only after the recording, when the patients or the parents were shown the video clips, they identified the sounds, and you could identify whether they were actually wheezing or not. And nearly 60% of the parents term it wheeze when it's actually upper airway noises or mouth breathing or just harsh breathing. So you have to be very careful to base your diagnosis just based on history. That's why the BTS guidelines very specifically talk about physician having auscultated wheeze. So according to the BTS guidelines, what are the main presenting features for you to consider a diagnosis of asthma? It's wheeze, breathlessness, particularly with exercise or any activity-related breathlessness, such as crying, laughing, a dry cough, and noisy breathing. So following this presentation, you would take a detailed history with physical examination to get an idea of the pattern of illness. What is the severity of the disease? What kind of factors contribute to exacerbating the symptoms? What will actually control the symptoms? And is there any other history to give you a clue to a differential diagnosis? So when you're starting to think, is this asthma, and there are some differential clues in the history, you obviously follow the relevant course of action, refer to a secondary care pediatrician or a tertiary if you're a secondary care pediatrician. If you think it's probably asthma, you start looking at what are the causal factors. You start finding out, do they have any environmental triggers? Do they have the newly acquired pets? Are they smokers at home? Do they have soft toys in their bed? Are they having hazardous mite allergy? Is it episodic? Is it triggered just by viral illnesses? Or do they have symptoms even in between episodes of viral infections? Are there any other comorbidities? Is the child like having symptoms suggestive of reflux? Are they regurgitating? Are they vomiting? Are they coughing and choking while they're swallowing, suggestive of aspiration from the top end or swallow dysfunction? So depending on what kind of responses you get to those questions, you will order differential diagnostic tests, or if there's no suggestion of an alternative diagnosis, then you trial your patient on asthma therapy. So it's a completely different talk. Once you put the child on asthma therapy, every single child who receives a trial of inhaled corticosteroids should have an asthma action plan. The asthma action plan will tell the patient, the parent, what is your preventative inhaled regimen? So what do you have to give regularly twice a day? What you need to do if the child is acutely wheezy, how many puffs of salbutamol, when do you take the child to A&E, GP, and the likes of that? What are the child's triggers and what they should avoid? So this is a huge diagnostic algorithm to talk about what are the differential diagnosis, what do you do, what are the tests. I'll be talking about it as we go on during the talk. This is just to show you what is the probability of asthma if there are certain symptoms, and if there is a low probability of asthma, what are the clues in the diagnosis. So the first thing you would do in a secondary care center, I've been told recently that quite a few primary care practices, GPs, have now have the facility to do spirometry. So it's a very briefly, you have to look at the flow volume loops, and this is what it looks like in a person who doesn't have asthma. So you have a nice, good inspiratory loop, and you have an expiratory loop, which looks like a triangle, which is not scooped out. Whereas in asthma, which is due to obstruction of the small airways, you'll see that the expiratory limb is scooped out. The inspiratory limb might be completely normal or might be slightly low depending on the severity of asthma. We'll not talk about restrictive and mixed patterns, but this is a clue. If you see a scooped out appearance, and of course you'll see the numbers, it should suggest that the child has obstructive airways disease, most likely due to asthma, depending on the symptoms. I'll show you some other flow loop patterns in this slide, which I will be giving you examples later on for a differential diagnosis. So if the child above the age of 5 or 6 years is able to perform spirometry, and you look at the flow volume loops, I showed you what obstructive flow volume loop will look like. So the expiratory limb will be scooped out, but in fixed airway obstruction, when they present with stridor, sometimes patient, obviously parent, or comes to you with a wheeze, this is the kind of expiratory and inspiratory loop. So the inspiratory loop is truncated, and as is the expiratory loop. And you see this with any kind of stenosis. It could be subglottic stenosis. It could even be laryngeal web. So something which is obstructing both the inspiratory airflow and the expiratory airflow. And with variable extrathoracic, the inspiratory limb is more truncated, and similarly with intrathoracic, the expiratory limb is more truncated. So if the child has a small airway obstruction as seen by the numbers, so the FEV1 is low, and so anything which is below 80% is considered low FEV1. But you don't just go on the FEV1, you look at the ratios, and if the ratios are around 85%, you consider it to be normal, because it depends on the ethnicity. Again, it's a completely different talk, so I can't cover it too much. If it is obstructed, then you would give them 4 puffs of the salbutamol to measure their salbutamol bronchodilator response. And the bronchodilator in this child, they did have a significant bronchodilator response, so anything about 12.5%. If your FEV1 improves by more than 12.5%, it is called a positive bronchodilator response. So you'll see the loop. So this is the one which I'm showing on my pointer. This is the loop before giving the bronchodilator, so at baseline, and after the bronchodilator, you can see the improvement in the expiratory limb. And if you actually look at the numbers, the pre was 59% and the post was 70%, and there was an improvement of 19.3%, which is a positive bronchodilator response. The other test we do is exhaled nitric oxide. Again, very briefly, in children, it should be below 20 parts per billion. If it is between 20 to 35 parts per billion, it is suggestive. It is an intermediate level. And if it's the first time you're performing it on a child who is steroid naive, it suggests that there is airway inflammation. And similarly, if it's more than 35 on the first occasion in a steroid-naive child, it is suggestive of airway inflammation. Very specifically, eosinophilic inflammation, but I'm not going to go into too much detail now. At your level, if you understand it, that exhaled nitric oxide is suggestive of inflammation in the airways. It could be eosinophilic or neutrophilic. In the past, we used to think it's exclusively eosinophilic airway inflammation, but we are changing the thinking now, and we just talk about airway inflammation. It could suggest neutrophilic as well, but I think at SD5 and below, you can think about it as eosinophilic airway inflammation very specifically. The other tests which we do, you might have a child who comes to you with features suggestive of asthma and have a completely normal spirometry and intermediate or normal exhaled nitric oxide. So the other tests which could support a diagnosis of asthma, a bronchial challenge test or airway hyperresponsiveness test, and different labs use different substances to cause the bronchial challenge. We use methacholine or histamine in our labs, but any of these three, sometimes even hypertonic saline, is used as the agent to produce an airway challenge. I'll talk about it in a minute. Eucapnic hyperventilation test is actually a very simple test, and it's considered a gold standard for diagnosis of exercise-induced asthma. We also use cardiopulmonary exercise tests very specifically for children with exercise-induced symptoms. And I'll talk briefly about continuous laryngoscopy during exercise. So the methacholine challenge test, this is a sequence how we do the methacholine challenge. If a child arrives in the lab and if the FEV1 is more than 60% predicted, only then you would produce to challenge them with methacholine, because it can cause significant bronchoconstriction. If the FEV1 is below 60%, you would not proceed with the test. So as shown here, the concentration of the methacholine, you start with a very low dose and gradually increase it. You do a total cumulative dose of 400 micrograms. In the past, we used to talk about PC20 and PD20, as in the concentration or the dose of methacholine, which is responsible to cause a drop in the FEV1. We are going now with the cumulative dose, a maximum of 400 micrograms. So if there is a drop in FEV1 of more than 20%, we'd say it's a positive methacholine challenge. If there is no drop despite giving 400 micrograms, you say it's a negative methacholine challenge. It's an extremely sensitive test. And if you've had normal non-obstructive spirometry with a normal methacholine challenge, you can 99.99% rule out a diagnosis of asthma. I'm not going to go into the details of this test. It's just to show you that it's a very simple homemade kit. It's called Eucapnic voluntary hyperventilation. As the name itself suggests, the patient, we usually do it in elite athletes who have very specifically exercise-induced symptoms. So we're trying to simulate hyperventilation associated with exercise while they're seated in a lab. So they actually breathe in dry air and hyperventilate at around 30 times FEV1 per minute for about 6 minutes. And if at the end of 6 minutes there is a 10% drop in the FEV1, we call it a positive test, very specifically for exercise-induced asthma. So this picture shows you a combination of CPET, which is a cardiopulmonary exercise test, and a continuous laryngoscopy during exercise. So it's very similar for both. With the CPET, they don't have the camera attached to them. So they're just running on a treadmill. You can also be going on an exercise bike. And we do pre and post exercise spirometry to identify whether there is a drop in their FEV1 post-exercise. The CLE, or the continuous laryngoscopy during exercise, you pass a camera through their nose. It's a nasoendoscope. Sits just above the larynx to look at exercise-induced laryngeal obstruction. In the past, it used to be called vocal cord dysfunction, but we've now identified different forms, types of vocal cord dysfunction, and this is exclusively for exercise-induced laryngeal obstruction. So this is what you would see when the patient is exercising if they do have exercise-induced laryngeal obstruction. So this is at rest. You can see the vocal cords are nice and widely abducted. So it's wide open, as it should be when you're breathing in. But with high intensity exercise, this teenager has both supraglottic structures paradoxically adducting, and so are the vocal cords. So this patient actually has both supraglottic and glottic closure, so obstruction with exercise. So this is just a video to show you what happens with exercise. So you can see there, the supraglottic structures are closing in when the child is exercising. And the people with astute hearing could have heard the sound, it is very similar to wheezing. And a significant proportion of our teenagers are tried on escalating doses of long-acting bronchodilators, Atrovent, and the whole cocktail of bronchodilators before they're referred to us to look for other differentials. And we found that roughly about 25% of our asthmatics have a component of laryngeal obstruction, particularly if they're very athletic. So these are the, I'm not going to go through the whole thing. These are the features which will differentiate between exercise-induced laryngeal obstruction and exercise-induced bronchoconstriction. But sometimes there is such an overlap, and you might need an objective test to be able to differentiate between the two. So what are the clues to alternative diagnosis in wheezy children? On the left, this is again from the British Thoracic Society guidelines. On the left, you'll see the clinical clue, and on the right, you will see what are the possible diagnoses. If the symptoms present right from birth, or if it's a perinatal lung problem, then you think about conditions like cystic fibrosis. Does this child have chronic lung disease? Is it ciliary dyskinesia? Or is there a developmental abnormality of the lung? If there is a family history of lung disease, again, you would think of cystic fibrosis, neuromuscular disorders. And if this is associated with severe upper respiratory tract disease or recurrent infections, you would think of immune deficiency disorder. The symptoms and signs which should direct you to alternative diagnosis are a persistent wet cough, excessive vomiting, swallow dysfunction, an abnormal voice or a cry, which should direct you towards a laryngeal problem. If you hear unilateral signs on examination, and if you hear an inspiratory stridor with a wheeze, and if there is failure to thrive, I will not go through the possible diagnosis on the right. You should have seen that. So what are the investigations you will do if it's focal or persistent radiological diagnosis? These are all the differentials you have to think of and proceed with investigations as required. Now, I will just very briefly, I have possibly around 8 to 10 slides, which will look at the common mimics of asthma, and most of these patients are ones that I have seen in my personal clinical practice. So here we go. So this is a 12-year-old child who had worsening shortness of breath and wheeze on minimal exertion for over a year. She had been diagnosed with asthma and received multiple courses of oral and inhaled steroids with minimal improvement. On auscultation, she had an inspiratory and expiratory wheeze, which was more noticeable when she laughed. So this is her spirometry loop. So you could see that she has a truncated inspiratory loop, but not so much, but the expiratory loop is much more truncated. Yeah, so the inspiration is more or less normal. So the dotted line shows what a normal flow volume loop should be. And as you can see in the chest x-ray, there is a widening of the superior mediastinum. And on the CT scan, she had a huge cystic mass, which is compressing the distal trachea. So you can see there's hardly any space here in the trachea towards the latter part, towards the distal end. So this was suggestive of a foregut duplication, and this was removed thoracoscopically, and she went on to be completely normal. So this child presented to us. I was a year 1 registrar, I think. She presented to us with recurrent wheeze, and the GP had put her on a course of inhaled steroids. She didn't seem to respond very well, but every time she presented with an acute wheeze to the GP surgery, she never went to A&E. It was always to the GP surgery. GP would prescribe her a course of oral steroids, and her wheeze used to go away. This went on for about 9 to 12 months when she was referred to us. So the ones who are really astute with good eyesight will see that there is a differentiation in the translucency. I'm sure you'll all agree with me. On the left, if you see, it's just a little bit more darker than the right. So it suggests there is a hyperinflation on the left compared to the right. So the CT scan on this patient showed that there was some sort of an obstruction on the left side, blocking off literally at the carinas. The left main bronchus was blocked. And this is what we saw on the bronchoscopy as well. So in fact, the left was almost completely obstructed, and on the right, there was partial obstruction. So what this child had was atypical mycobacterial infection with granulomatous lesions throughout her airway and in the mediastinum. So this child was given atypical mycobacterial treatment for about 18 months to 2 years, covered with steroids, and she responded to the treatment. This is a 10-year-old previously healthy child presented with episodic wheezing, breathlessness, progressive exercise intolerance, which had developed just in the last 6 months. On examination, he had bilateral expiratory wheeze and had multiple courses of all asthma medication, which was escalated quite high. And if you can see the inspiratory loop completely normal, expiratory loop practically non-existent. Yeah, so this child actually had a intra airway, so literally at the carina towards the distal part of the trachea, he had a mass, a tracheal mass, which was excised and was completely normal after that. 40-year-old with persistent wheeze, despite high dose of inhaled corticosteroids, montelukast, intermittent oral steroids, all the patient had was bronchomalacia. So you can see here what it looks like at end inspiration, and here what it looks like at end expiration. So tracheobronchomalacia was confirmed bronchoscopically in this child. This is a 4-year-old with worsening wheeze and wet cough for 1 year, received again antibiotics, GPs from her GP and inhalers. On examination, decreased air unilaterally. And the CT scan showed a huge cystic mass, which was a cystic teratoma. She had it since birth, and she only presented at about 4 years of age. 15-year-old boy with poorly controlled asthma. He was treated with the asthma medication for nearly 15 years of his life. He had symptoms right from birth. He had a large cystic adenomatoid malformation on the right side. I don't have to point it out. There you go. It's a huge, big lesion there. I'm getting tired of showing you all these examples now. 8-year-old with recurrent persistent wheeze since infancy. This is someone I only saw last year here at the Brompton. So these are all her x-rays when she presented to her local hospital. You can see it's just a little bit busy, suggesting of maybe a bronchopneumonia or a pneumonitis. It always used to be triggered with the upper respiratory tract infection, but you know, nothing really exciting. If you look at the right and the left heart borders, apart from perhaps on this, they're usually clear, but it's just a little bit busy. So nothing really exciting on the x-ray. But when she had a CT scan, this showed a double aortic arch. You can see the indentation there, again at the distal part of her trachea, almost at the carina. And after surgery, after it was repaired, you can see it's completely gone back to normal and her symptoms completely disappeared. And she was on escalating doses of steroids. I'm just showing you all these examples that you just keep an open mind and always look out for differentials and clues to a differential diagnosis if the child is not responding to your trial of inhaled corticosteroids. There's no point in constantly escalating the treatment. You have to come back to the basics and revisit the diagnosis. So when would you consider the referral of children with suspected asthma, either to a tertiary or a secondary care? If the diagnosis is unclear or you're in doubt of the diagnosis, if the symptoms are present from birth, the child obviously needs further investigations and looking into. Excessive vomiting, we talked about reflux, or does the child have some sort of a gastrointestinal structural abnormality? severe recurrent upper respiratory tract infections, persistent wet cough, a family history of lung disease, failure to thrive, unexpected clinical findings as in focal signs in the chest, failure to respond to your trial of inhaled corticosteroids, and extreme parental anxiety. So to summarize what I have discussed so far, all that wheezes is not asthma. So not everyone that wheezes has wheezing, as shown in the first couple of slides. Not everyone with wheezing has asthma, and not everyone with asthma has wheezing, because different children can present to you in different ways. So asthma is a clinical diagnosis which is supported by your history, diagnostic tests, and a therapeutic trial. So if you're in doubt of the diagnosis, please refer the patient. So here we go. It's time for a mini test, and I will take any questions at the end of this test. So which of the following symptoms are more predictive of exercise-induced laryngeal obstruction compared to asthma? It's very basic here, so don't think too much outside the box. So if the patient presents to you with exercise-induced breathlessness, throat tightness, inspiratory wheeze, expiratory wheeze, or coughing with exercise, I'm happy for you to shout out, or I'm happy for you to put this on the chat. Liz, perhaps you have to unmute everybody.
I'm trying to unmute everyone, but it's not quite working.
Okay, so never mind, maybe I shall give out the answer. So very specific to exercise. So all these features can, the patient can come to you with any of these presenting complaints basically, but throat tightness is very, very specific for exercise-induced laryngeal obstruction rather than asthma. Can't move on. Okay. Which of the following indicates a diagnosis other than asthma? Recurrent cough or wheeze that responds to salbutamol, recurrent or prolonged wheeze or cough that does not improve with inhaled or systemic corticosteroids, normal spirometry, a fractional exhaled nitric oxide less than 20 parts per billion, or no wheeze. Yeah, I can see some responses on the chat. You're right. The response is recurrent or prolonged wheeze that does not improve with inhaled or systemic corticosteroids. Why am I not able to move? Okay, here we go. This is, let's see how much you understood about flow volume loops. This is a flow volume loop taken from a 6-year-old child with persistent wheeze. What is the most likely diagnosis in this child? Is it asthma? Is it variable intrathoracic obstruction? Is it variable extrathoracic obstruction? Or is it fixed upper airway obstruction? Or is it none of the above? Nice to know some of you are thinking. Okay. Good. Sorry, I mean, I thought we would have the voice here. I think there's a bit of confusion whether it's A, B, C, or D. The correct answer is fixed upper airway obstruction. You can see, unfortunately, you can't see the dotted loop, but the inspiratory loop is truncated, as is the expiratory loop, suggestive of a fixed upper airway obstruction, such as subglottic stenosis, which could be iatrogenic, which could be a complication of bacterial tracheitis, road traffic accidents, and you see all sorts. But it suggests that there is subglottic stenosis. Okay, is this chest X-ray normal? Very simple answer. Someone says, no, it's not normal. Why is it not normal? Nuha. You say it's not normal. Sam says it's not normal. You're right. Why do you think it's not normal? Chest cavity, the shape. Good, you're right. I'm just being naughty here. It's not even the X-ray of a human. It's the X-ray of a piglet, which we took when I was doing my bronchoscopy course in Nice. So I think you all got that. Yeah, excellent. Dextrocardia abnormal chest cavity. Well, I'm happy you identified it as an abnormal chest X-ray. Yeah, so I'm happy to take any questions if there are. It was meant to be a very basic diagnosis and differential diagnosis and the mimics of asthma, and I hope I have covered most of the topics that needed to be covered in this talk. Okay. If there
Wow,
are no...
thank you so much, Sam.
Oh, I was expecting a few questions. I left the last 15 minutes for questions, so no questions. Okay.
Oh, wait a minute. There's a question from someone.
If there is an underlying, no, that child didn't have any underlying issues. In a child who presents with such a severe atypical mycobacterial disease, we look for interferon deficiency and complement deficiencies. This child was immunocompetent and didn't have any underlying problems at all. It was just a one-off, did really well. Okay. Okay, if there are no other questions, shall we call it a day then, Liz?
Yeah, thank you so much again, Sam. I've posted the link in the chat. Please give feedback on the teaching. Thank you so much for joining. Please join us again tomorrow lunchtime at 1 p.m. and this evening there's teaching as well at 6:30. And yeah, thank you so much again, Sam. That was great. There was something for everyone.
Okay, thank you. Cheers. Bye.
Bye.